And this is how these epidemics occur and have occurred in our society. The condition is known to occur. Everyone understands. Oh, everyone knows there's whiplash. Everyone knows lots of people get back pain. Everyone knows lots of people get carpal tunnel. Everyone knows lots of people get, reflux, GERD, or one of our epidemics. And physicians validate it, of course, because the physicians are only looking below the neck. They're only looking at their little body part. You go to the bone doctor, they look at the bone. You look at the stomach doctor, they look at your stomach. No one's really looking at the whole thing. And insurance covers it. Symptoms worsen. And the syndrome begins to take a life of its own. With things like fibromyalgia, there's support groups. And interstitial cystitis, there's support groups. So you see lots of other people who have it, which is very similar to what I described with Dr. Charcot back in France, where you went into the hospital and you saw lots of other people who were ill, and you got worse. And so sometimes support groups actually make people worse. Sometimes defining a disease as a disease makes people worse. So I never say, and some of you have been to me, of course, and I never say fibromyalgia. I say fibromyalgia symptoms, because I don't want to call it that name of a disease, because I don't think it is a disease. I think it's a mind-body syndrome. Let's talk about back pain for a minute. 40 to 60% of people who have no back pain, zero back pain, have abnormal MRIs of the back. They have degenerative discs, they have arthritic changes, spondyloarthropathies, they have bulging discs, herniated discs, facet disorders. All these things are seen in people with no back pain. So if you happen to have back pain and you go to the doctor and you get an MRI, well, it's likely to show that something's wrong. So what has happened now? You walk into the doctor with back pain. You walk out after your MRI with a back problem, a bad back, a disease. And what's the expectation then that you have in your mind? You're going to get worse, or you're not going to get better, because there's something wrong. And when they do these studies, they've also followed people over time. And when they follow people over time, there's no correlation between back pain and the MRI findings. In some people, the MRI gets better, back pain gets worse. In other people, the MRI gets worse, back pain gets better. There's no relationship to that. And so we have to understand that medicine has advanced in a lot of ways, but it doesn't understand this mind-body syndrome stuff. And it can lead us astray because of the way it defines illnesses. This is another study from Britain, the exact same thing. Another MRI study with and without back pain, following people over time. No correlation between MRI findings and back pain. And this is a very important article in the New England Journal of Medicine almost 2 years ago now, by a famous orthopedic surgeon from Stanford. And he tells us that these findings on MRIs are common. We would expect that they would happen. And baseline MRIs nor follow-up MRIs are useful predictors of low back pain. And he says MRIs are helpful if you're worried about an infection, cancer, or a fracture. But they're potentially dangerous if you're doing MRIs on people with garden variety back pain, where it's very unlikely they have an infection, a fracture, or a cancer. Because when we make diagnoses based on these imaging studies, we're likely to reinforce the suspicion of serious disease, make people think they're more sick than they are, magnify the importance of nonspecific findings, and label patients with spurious, which means fake or wrong, diagnoses. And it's that labeling that can do us harm. And what's nice for this practice for me is when I see people, they may come in with a list of 2 or 5 or 10 diagnoses, but they may walk out with only one, which is TMS, which is curable, as opposed to 10 which are not curable. And that's a huge benefit that we can provide. And I had a lady last class who was scheduled for back surgery. The surgeon said, yeah, we're going to operate on you. We're going to fuse your spine. And she somehow found me. She somehow found this program. And 2 to 3 weeks later, back was fine. And the surgeons are calling her and saying, well, when are you going to have your surgery? And she's going like, I don't think so. I don't think so. So this study, this was done just this past December, published in the Journal of the American Medical Association, was a randomized trial comparing with people with sciatica, not just regular back pain, but more severe pain that was shooting down the leg, presumably due to something pressing on the nerve. And even in this situation, was not just garden variety back pain, but with sciatica, even in this case, there was no difference at 2 years between the people who had surgery and the people who didn't have surgery. And if you talk about the garden variety back pain without the sciatica, the surgery is even less effective than in this situation. So there's a lot of operations being done that maybe don't need to be done. For example, here's a study that was published in the New England Journal of Medicine a few years ago now on knee arthroscopy. They were doing knee arthroscopy for arthritis. There were 650,000 of these done per year at a cost of over $3 billion per year in this country. And somebody decided to do a research trial where they did the surgery versus the sham surgery. So this is knee arthroscopy, right? So half the people got the knee arthroscopy for arthritis, where they put the little tubes in and they wash out the knee and clean it up. And the other people went to sleep, got the holes made, but nothing was done. Okay? Fake surgery. And guess what happened? There was no difference between the two groups. And you can see on the slide, there was no difference between the people who had the real surgery and the fake surgery. But a lot of people got better. Why do you think they were doing this? It's because people got better. Why were people getting better? Why were people getting better? They thought they were going to get better. They had something done which was supposedly to make them better. They had surgery. And so what do we call this? It's the placebo effect. It's the idea that if you think you're going to get better, you probably are. And what do we call, here's this extra credit now, what do we call the opposite? Where with the whiplash situation, where you think you're going to get worse. That's called the nocebo effect. It's the opposite. If you think you're going to get worse, you're more likely to get worse. And we're doing that in medicine a lot with these common